these are one-page notes on appendix. Let's learn about appendix in these one-page notes. So first of all, most common position of appendix is retrocecal, okay, and the second most common position of your appendix is pelvic position. Least common and most difficult to diagnose position of appendix is posterior. Now appendix is usually seen at the junction of three tenicoli, okay, and the other important things we need to remember about appendix is supplied by an end artery, that is appendicular artery. Appendicular artery is the branch of your lower division of ileocholic artery, and this is basically a end artery. Then we have accessory appendicular artery, that is also known as the artery of Sheshanchalam, and branch that is a branch of posterior, that is a branch of the posterior cecal artery. Okay, what else about appendix we need to learn? Okay, let's look at the acute appendicitis. So acute appendicitis can be of two types, that is obstructive and catarrhal. Talking about the obstructive type of acute appendicitis first. So obstructive type of acute appendicitis occurs due to fecalith. Fecalith is the most common cause. Apart from that, ascariasis, foreign body, and carcinoid. Then there is catarrhal or non-obstructive type of acute appendicitis that is common in case of children. C for catarrhal and C for children. Remember like this. Then we have a Mantel score for acute appendicitis. This Mantel score is based on the clinical features of acute appendicitis. So the clinical features can be remembered by the mnemonic mantras, that is migration of pain is given 1 point, anorexia 1 point, nausea and vomiting 1 point. These are the symptoms, okay. Then tenderness and rebound pain. Tenderness is given 2 points in the Mantel score, and rebound pain is given 1 point, elevated temperature 1 point, leukocytosis is given 2 point, and shift of WBC to the left is 1 point, okay. So these are some symptoms, sign and lab findings that come under Mantel score. Then remember that if the score is less than 5, then appendicitis is unlikely. 5 or 6, then it is possible. 7 or 8, it is likely, and 9 or 10, it is highly likely, okay. And we also have some other scores for diagnosing acute appendicitis, that is your Znaki score and Ripasa score, okay. Now we will talk about the important signs of acute appendicitis. There is a Rovsing sign. Rovsing sign means there is pain in the left iliac fossa when you press the left iliac fossa, it will cause pain in the right iliac fossa, okay. And Psoas sign or Cope-Psoas sign is hyperextension of your right hip and flexion of the right hip against resistance. So if we do hyperextension of the right hip, or we flex the right hip against resistance, so there is pain, okay, in the right iliac fossa region. Then we have obturator sign. Obturator sign is flexion and internal rotation of the right hip will cause pain if the patient is having acute appendicitis. Apart from that, we have Dunphy sign. Dunphy sign is pain on cuffing. Tenhorn sign is pain on pulling the right testis. Then Aron sign is firm pressure in the right iliac fossa will cause pain at the epigastric region. Now, differential diagnosis of appendicitis in infants and children. The differential diagnosis can be Yersinia enterocolitis, can be intussusception, can be bowel obstruction, ureteric colic, and Meckel's diverticulitis. In adults, the differential diagnosis can include ureteric colic, gastroenteritis, bowel obstruction and torsion, and in adult female, it can include Mittel-Schimmer syndrome, endometriosis, PID, and ectopic pregnancy. So remember the retrocecal appendicitis. In retrocecal appendicitis, we usually find Psoas sign, and in pelvic appendicitis, there is pelvic diarrhea or tenesmus and increased frequency of micturition. On DRE, there will be pain in case of pelvic appendicitis. So these are some important points about acute appendicitis. Next thing we need to remember is the laparoscopic appendicectomy can be done Laparoscopic appendicectomy is done with the help of 3 trocars. One trocar is inserted infraumbilical, another one at the hypogastric region, and another one in the left iliac fossa region. Okay, then what are the complications of appendicectomy? So before the complications of appendicectomy, how do we manage appendicitis? Appendicitis may we perform open appendicectomy, we can also perform laparoscopic appendicectomy. In open appendicectomy, we have some special type of incision, that is your McBurney incision, Lance or skin crease, or Bikini incision, Rocky Davis incision. So one by one we will learn about this. McBurney incision is given in emergency condition, and McBurney can be of two type, that is gridiron, जिसमें we perform muscle splitting, and Rutherford, in which we perform muscle cutting. Then we have Lance incision. Lance incision or skin crease Bikini incision is done for interval appendicectomy. Then we have Rocky Davis incision. Rocky Davis incision is your lower midline incision and done when there is appendicular perforation. Okay. Now what are the complications of appendicectomy? Remember that iliohypogastric nerve can be damaged, can lead to right inguinal hernia. Wound infection is the most common complication of appendicectomy. Then fecal fistula, portal pyemia, stump appendicitis, and adhesive intestinal obstruction is most common long-term complication. Then there are okay, now let's learn about appendicular lump. What is appendicular lump? Appendicular lump, when there is increased amount of inflammation in the appendicitis, it can develop into a chronic form, that is known as a appendicular lump. And in case of appendicular lump, the important thing you need to remember is the management part, that is we perform Ochsner-Sherin regime, that is a conservative management. And in Ochsner-Sherin regime, we make the patient nil per oral, we give IV fluids, we give IV antibiotics, and we give painkillers. So if the patient recovers after your Ochsner-Sherin regime, then the recovery signs will be the pain of appendicitis will decrease, the size of appendix will decrease, and fever will decrease. Okay. Now if there is discharge on third or fourth day, then we perform at 6 weeks we do interval appendicectomy or elective appendicectomy. Okay. Now if the patient is not responding to Ochsner-Sherin regime, we will monitor the vitals of the patient, we will monitor the temperature, size and tenderness of appendicular lump. And remember that the patient, if it doesn't respond, that is if the size of the appendicular lump is increasing, pain is increasing, fever is there, then it might be that the appendicular lump has been converted into appendicular abscess. So we will discontinue this Ochsner-Sherin regime and we will go for extraperitoneal drainage of the abscess. Okay, so this was about the appendicitis. In the next video we will learn about the appendicular tumor, pseudopyxoma peritoni. Thank you for watching this video.